So, we've all heard the adage that even non-nuanced scientific findings take 18 years to get put into practice, but when we have conflicting results or results that may vary pending patient characteristics or patient populations, I imagine that becomes much more confusing. Again, how do we help clinicians, sort of in the clinics and in the practices navigate this scientific evidence as it comes out, help to interpret it, so that they're not spending their days reading, they're treating patients, not reading JAMA or the other journals.
Sure. Well, I think that's where professional societies, where specialists have a role to be able to sift through the data and interpret it. I think the other area where we can make more strides are decision support tools for providers at the point of care that would say, based on these characteristics, the patient you're seeing fits into a characteristic very similar to the SPRINT study group or another study group, and therefore here's what would be recommended. Mm-hmm. I think there's a little bit of that, and I think you're going to see a whole lot more of that in the near future.
And that's actually what happens on the managed care side. Mm-hmm. So on the managed care companies, we publish what are called clinical practice guidelines, mm-hmm. and we make those available as tools to the clinicians in our network, really as a guide to help drive some of their decisions, with giving them some autonomy to individualize the care plan. Because again, as we found out, one solution doesn't solve it for each diabetic.
But we have to make sure that those guidelines are not 18 years old.
Absolutely.
And that's the dilemma, that I'm still getting emails or letters from various pharmacy benefit managers saying, here's a patient with diabetes who is not receiving an ACE or an ARB. Why not? Right. Of course, they're not knowing that the patient has had hyperkalemia and was intolerant of those medicines or has low blood pressure. So we really need to somehow integrate the journal findings and the latest developments and the latest understanding of professional societies into what we provide to clinicians to help them manage their patients.
Mm-hmm. And I think the data needs to be a lot better. I think that's one of the challenges. Each group that is trying to track this has their own sets of data. We as clinicians have the data in our electronic mm-hmm. health record. From a payer perspective, you have your data, which is not necessarily the same. And so integrating that more effectively would be a huge mm-hmm. step forward.
Well, that's happened in a lot of areas of healthcare where, Dartmouth obviously has made the study of variation mm-hmm. across clinical practice, quite well known. And a lot can be learned there. There's clearly variation here, but some of that variation is warranted, as we've discussed, based on clinical characteristics and patient comorbidities. So I guess the question is how we sort of assemble that, recognizing the need for customization, but bring the evidence, or as much evidence, to base. John, I want to go back to you. It sounds like you're trying to do some things as a health plan to educate providers. How receptive are they? The health plan sort of coming at you with a clinical practice guideline. I could imagine that being received well in some cases and perhaps not so well in others.
You nailed it, exactly. And there are some providers that don't mind partnering with the health plan, and then there are other providers that feel like, I've been trained this way in residency, and this is the latest my medical society is telling me, and I'm going to follow that guideline. Again, we just like to stay on the sideline as a partner to ensure that whatever method they're using, they're driving towards quality improvement. And so whatever path gets them there in the safest tolerable way for our members is really the ultimate goal.
Mm-hmm. Bob, maybe I'll ask this as of you. You talked about data and maybe the need to, or the opportunity to sort of assemble better data. What might that look like? I could imagine, you would have characteristics of patients, maybe some of their history, different drug regimens and choices, information on behaviors, exercise, diet, other clinical comorbidities. You can imagine putting that together in a data set and looking at associations. This would not be experimental studies, but I could imagine some of that could be valuable from a clinical perspective.
Oh, absolutely. But even with the data that we already have available, I think we can have better tools. So for example, at Joslin, we've developed a Joslin Clinic Analytic tool that tries to take data that is in the electronic health record that all providers have, medications, laboratory data, some basic demographic, and attempt to create different goals for the population and subgroups. And you know, there's really, I think the field is at its infancy in terms of doing that, but that's sort of what we need. We need more nuanced measures of quality that take into account a lot of other factors. And, you know, we're struggling. And then patient-reported information is rarely ever integrated into any of these kind of measures, much less socioeconomic status and other. You could imagine a whole series of variables that could be included. But even the first step, we found this as a helpful tool in working with clinicians around the country to guide them on subpopulations where there are gaps of care that could be addressed.
Oh, I was just going to say that actually AAMC just recently had sponsored a project to bring together numerous hospitals to contribute data in a de-identified form for research, so that you can look at a much larger population than tapping into any single health record system. And so I think we need more of that kind of collaboration between hospitals, private, public, universities, large healthcare systems, to bring the data together so that we can look at these larger, much like the European countries can do, where we can see the entire population.
Well, one thing though, I don't want us to run off to, I think it's great and we should do all these things, but it also, I don't want the message to be that that's what we need in order to improve care, because I think right now you can identify, and I don't think this happens in a lot of primary care practices, patients that have an A1C greater than 9 that have not been seen in 6 months and do outreach, and that's clearly effective, and that doesn't need the complicated, while we're building that, we should be able to do some very practical kinds of things.
I mean, certainly you don't want to forget the micro level when trying to address the macro need. I agree completely.
And I was going to say that's also under the belief that the provider has an electronic medical record system.
Yes, right.
And is able to effectively do population health, which gets to the whole PCMH model that a lot of the managed care community endorses, the ACOs, accountable care organizations, and PCMHs, to incentivize providers to share in the risk of managing patients to improve outcomes. So a better way to do that would be EMR.
Sure, and fortunately, I think we've made great strides, in the U.S. in terms of the number of providers that have electronic health records. It's still not where it needs to be. And then, of course, there's the challenge that those electronic health records are not always great systems to be able to extract data from, and that's
so
obviously the big challenge.
So many different platforms that don't speak to each other.
Yes, right.
So you mentioned the PCMH model. How is that playing out for diabetic patients? Because there's an element of having a sort of a coordinated locus of care, but there's also, as we've talked about, the need for a care team, educators, nutritionists, potentially pharmacist involvement. So after hours appointments or being available on weekends, some of those components of the PCMH are good, but there are other dimensions as well when we think about care for diabetes. You've studied this, Bob.
Sure, yeah. No, I mean, a lot of the early pilots around the patient-centered medical home really revolved around diabetes for the reasons that a lot of healthcare changes typically, historically, have always been around diabetes. It's a common disease. It's measurable in large part, although you might debate where the goals should be, and it's very costly, and so it's a natural target. And so I would say that if you look at all the evidence, there has been significant improvements in diabetes care by moving towards a patient-centered medical home model. But that in and of itself is not the full answer, because again, only a portion of healthcare happens within that practice. And small practices may not have all of the different types of professionals that can help. So you mentioned diabetes educators and dietitians. A typical primary care practice isn't going to have that embedded in the practice, and that's where centers of excellence can, in diabetes, be able to send people, educators, dietitians, to various primary care practices once a week or whatever.